Hey, good morning. Um, Dr. Robin Trotman, infectious disease doctor at Cox Health in Springfield. We're going to take a minute for people to log on. I think it's um, been 3 or 4 months since we got together and talked about this pandemic. A little bit's changed since then. Uh, we'll give it a minute for people to log on. Um, and have a pretty robust, long agenda that's going to go real fast, rapid fire on some topics that I was asked to address, some topics that I want to address, questions that I'm receiving, and things that I think are important and relevant. And hopefully we'll get to a point where people can put questions in the chat box. I guess it's message box or chat box, and then we'll have people monitoring those questions. It looks like people are still popping in, so we'll give it another minute and we'll start in. So yeah, I plan on sort of doing rapid fire description of the current situation and where we've been overall, and just since our last update. We'll do that for about 20 minutes and then hit some of these common questions. And then hopefully by 25, 30 minutes, we ought to be ready to start fielding some of these questions. So I thought we'd start today talking about a little bit of background. And I made some notes to cover. And I think that by me talking about the timeline and the history of the development of our vaccines, really one of our main goals right now is to help people understand the safety and efficacy of these new vaccines to help with vaccine uptake. We still have a lot of people that have questions, and understandably so, about these vaccines. But man, we have a ton of data. We have a ton of evidence that these are safe. And so some of the questions go back to things like, how did this vaccine get approved so quickly? What is an emergency use authorization? These vaccines aren't actually FDA approved. And so in order to understand what that means, we really have to understand the timeline of how we got these vaccines. So let me just digress, sit back, relax, enjoy this little history review of how far we've come in such a short time, and why I want people to understand that those guardrails and those safety processes that go through typical development of a drug or a vaccine, they haven't been bypassed in any way. They've just been accelerated. So let's think about, go back to November 2019, and in China, there was an unidentified, strange, often severe respiratory illness. So November of 19. And then in January 9th, the WHO said, hey, there's this virus that's causing this syndrome that looks like SARS. And by January, we had a sequence of the virus. We had the RNA in the virus sequence. So we knew all of the blueprint, all of the genetic material of the virus in January. That's fast to go from describing an illness to finding the bug, to sequencing the bug, and then to sharing those sequencing data across the world. Then January 21st was our first identified case in the US, in Seattle, if you'll remember that. So we also, about that time, figured out there was human-to-human transmission. If you remember, originally, they thought it was going to be what's called zoonotic, meaning straight from the animal to the person. And it really took the folks in China a couple months to discover or to release the information that, no, this is indeed transmitted from person to person. And then, so that puts us at mid-January, and then by early March, the WHO described this as a, quote, pandemic, meaning it's going to affect the entire world. And then March 13th, the US declared it a national emergency. So syndrome in November, March, it's a national emergency. And then July 14th, we had the original data on the safety of the Moderna vaccine. So as soon as we sequenced that virus in January, they started looking at using RNA technology, which the virus is an RNA virus. We can sequence and make RNA in a lab on the order of kilograms. It's a It's just molecules, but we can make buckets and buckets of this stuff. So it was decided, since we had experience with using RNA vaccines in the past, not commercial experience, but experience using this as a platform, it was decided to use those as some of our key strategies to building a vaccine rapidly, inexpensively, and on a large scale. So July, we had our first Moderna data. Then July 27th, Moderna phase 3 data came out. We started with those trials, or didn't come out, started those trials, the phase 3 trials. And keep in mind, it's a lot easier to do a trial when a disease is prevalent. So when you're looking at the efficacy of a vaccine, if you have a high disease burden, a lot of people getting infected, you're going to see separation in the vaccine and the placebo quicker. So those trials ran really quick because, if they enrolled 17,000, 20,000 people in the vaccine arm, there were enough infections in the placebo because the disease was so rampant at that time that those trials went very fast. Because so many people got sick in the placebo arm, you have to stop those trials. You can't keep giving placebo when you clearly have a safe and effective vaccine. So by the end of January, the government had invested in, by August, the Trump administration had allocated 1.5 billion for 100 million doses. So the government was subsidizing these vaccine trials and buying the vaccine in advance. Typically, the way a drug study works is you do a phase 1 study, you stop, then you do a phase 2, stop, and the drug companies have to raise money. There's venture capital. They have to raise the money to build the vaccine, but they don't do that until they have proof that it's safe and effective. In this case, the vaccine doses were purchased before the vaccine was actually manufactured. So that long step of having to go out, raise money, and manufacture the vaccine, that was all done pre-approval, which happened in December. So we started the phase 3 trials into July, and then December 10th, the FDA advisory group approved the Pfizer vaccine. You remember how rapid fire this was. December 11th, the emergency use authorization was released. December 7th, Moderna went through the same process, the FDA advisory group, and then the EUA. So all of that happened really in the span of under 1 year from having the sequence of the virus. The process was the exact same as typical approval of a drug, except for we don't have years and years of outcome data. Really, the difference in an EUA and a full approval would be, do we know after 3 years if this vaccine still works? Well, no, we don't have that luxury, right? We're in the throes of a pandemic, and we have, 2,000 to 3,000 people dying a day in the U.S. Like, it would be unethical to wait for 2 to 3 years on efficacy data when we need the vaccine now. So that's really the main distinction. People should understand the safeguards were there. I've reviewed the data very closely. We have ongoing post-marketing data. It's not post-approval data where we know what's happening to these people. We're reporting that. We have active surveillance with an app where people can report side effects, and there's a heightened sense of awareness looking for side effects. So far, none of the guardrails, none of the safety protocols for typical approval of a drug or vaccine have been bypassed. It's really about not having full approval because of that long-term efficacy data. But we need to get out of the throes of this pandemic today, so we're not going to have that luxury. And then a lot of people ask me, will there be a full approval for this vaccine? The drug companies may not have the incentive since the vaccines have already been purchased, so they're not going to have that incentive to go for full approval. But clearly, the numbers needed to receive full approval, they've already been accomplished. The safety's there. It's more of a logistical process. And that may happen in the future, especially if we go to things like a booster, especially if we move into giving it to younger age groups. So that's sort of the history that I hope people will appreciate how rapid this process was, yet what was actually going on. These trials were being done in parallel. So we already had phase 1 data right off the bat. I was following the Janssen study early on last summer when they were giving it to monkeys and showing that when they gave SARS-CoV-2 infection to the monkeys after vaccine, they couldn't get the virus out of their nose or their lungs. Really incredible preclinical data on these vaccines. But at the same time, they were starting to manufacture the vaccine, hoping that it would be safe in the animal models so they could deploy it to people. But those trials still happen. They just started making the vaccine for the humans in advance, anticipating that it would be safe. But the same safeguards were in place. So let's pivot to some data, and I'm going to talk about the vaccine process in the state of Missouri and then here at Cox Health. Keep in mind these numbers move, but I believe in Missouri there have been about 2.5 million doses of vaccine administered. And what that means is about 1.5 million people have received the first of a 2-dose series. The Johnson or the Janssen vaccine is a 1-dose vaccine, but we haven't received very many doses of it. So really we're talking about the 2 mRNA vaccines for the most part when we talk about these numbers. But 2.5 million doses in Missouri, with about 25% of eligible people having received the first dose. So here's some good news. 66% of those over 65 years old have had a first dose. That's a big deal. I mean, that's starting to get to having some degree of baseline protective immunity in that population of 65-year-olds. And having taken care of hundreds or thousands of COVID patients in the hospital, age is really the big risk factor. That's the really vulnerable group. So it was super important that we prioritize those. We did that at Cox Health, even within our phase 1b/2, people with certain medical conditions. We really prioritize the older patients first, and we're seeing that bear out in the fact that hospital admissions are coming down, deaths are coming down. Here at Cox Health, we've administered 61,000 doses approximately. That's probably changed since this morning. We have 7,000 approximately healthcare workers that have received a dose of one of the 2 mRNA vaccines. So that's good news. I mean, I think we have 12 to 13, 14,000 people that work in and about our healthcare system. So we're maybe at half. We really want to get that number up. It's a big deal to have our healthcare workers safe. And here's the reason why. At the height of this disease, we had 15 to 20 healthcare workers testing positive per day. So people who work at or in Cox Health, 15 to 20 per day testing positive. Most of these infections were in the community. We know that. We did tracings. We had some people get sick in the hospital, but it was rare. And it was often healthcare worker to healthcare worker. Rarely was it a known COVID patient transmitting to a healthcare worker. Those number of infections really stabled off when we went to universal masking. We proved with 100% certainty that wearing that mask on the patient and the healthcare worker prevents transmission, because we had on a daily basis dozens of patients come in with COVID-19 unannounced, healthcare workers wearing a mask, eye protection. They treated the patient unknown that they had COVID at the time, and the healthcare workers didn't get sick. So we track those exposures, and we can say with certainty that those masks work to prevent transmission from infected people, especially when both people are wearing the mask. But looking back, if we had 15 to 20 healthcare workers testing positive per day since the vaccine, since the prevalence has gone down in the community as well, of course, we know that, we have about 1 healthcare worker per day. So we went from 15 to 20 at the peak down to about 1 person testing positive per day. We went from a peak of 500 leave of absence, so 500 healthcare workers with a leave of absence to either care for their family or out of work for isolation for themselves, down to about 23 in March. So these are really impressive numbers. It's really helped stand up our healthcare system. We now no longer are at crisis level in some of our mitigation strategies. So super encouraging. And if what's happened within the healthcare, and this is not unique to Cox, as I talk with colleagues around the U.S. I mean, this is a common theme. We're all really enjoying the having all of our coworkers back. It's good to see people not getting sick. We haven't had any healthcare workers sick in the hospital and since the vaccine rollout. The other question people are going to have is it safe? That's the big question. And in our little bubble of having given 61,000 doses, we've had 1 person that ended up in the hospital with some type of severe reaction. Don't know if it was specifically related to the vaccine. We have had people that have had vasovagal, meaning they feel like they're going to pass out. That's common with all vaccines. I've been asked, why does this vaccine have 6% fatality rate? That's not even remotely a number that we're dealing with. We haven't had anybody die from this vaccine. And now we're talking about end of December. So, we're talking about good 3 to 4 months of, Pfizer was a couple weeks before. We're talking about going on 4 months of safety data where we have no signals of any serious adverse events other than some of those immediate allergic type reactions, which are pretty rare. They almost always happen during that observation period. You get the vaccine, you have to stick around for 15 minutes or so and be observed. So any reactions that we've seen have usually occurred during that time period. I want to talk now about some exciting data. This is going to be my editorial liberty to translate some of the science that's come out in the last couple of weeks, and talk about some highlights and some encouraging new evidence. So, in MMWR, the journal for the CDC, this week, there was a study published where they vaccinated a bunch of healthcare workers. And then they subsequently tested them in their nose for SARS-CoV-2. And we know that the vaccine is almost 100% effective in preventing you from getting sick and in the hospital and dying. We know that it's about 80% effective in preventing you from having a positive test. So people are still going to get infected. They're still going to cough and sneeze on a vaccinated person. So we're still going to be able to find virus in the nose of fully protected and immune people. The good news is they don't go on and get sick. So we call that asymptomatic infection. So they're infected. There's virus in their nose, but they're asymptomatic. So what they did is they vaccinated all these healthcare workers and then they tested them, and they found that it's almost completely protective against asymptomatic infection and no subsequent transmissions. So this study, an MMWR multi-site study, very encouraging that when you get the vaccine, not only do you not get sick, but you don't have much virus in your nose very often, even when exposed, and you don't transmit. Another paper from the Mayo Clinic, they looked at their pre-procedure testing. So if you come in, get admitted to the hospital, or are going to have surgery or a procedure, we often do a swab in the nose to see if you have COVID in your nose, if you're asymptomatic and infected. And they looked at about 40,000 people in December and January, when the height of the pandemic, when there was the prevalence was really high. And they found that of those people that tested positive pre-procedure, totally asymptomatic, there was about an 80% protection conferred by having received the vaccine. So of the people who tested positive, very few people had been vaccinated. So what that means, that's in two different ways, that in two different pieces of evidence have studied vaccinated people, do they test positive? And then of the people who tested positive, how often they were vaccinated. So we looked at the same phenomena in two different ways, and we have about the same results. So that's really encouraging to me that these vaccines are pretty effective in preventing asymptomatic infection and transmission. Another couple of pieces of good information, some encouraging data are about our monoclonal antibodies. So if you do get sick and you're in one of these high-risk age groups, for instance, older, or maybe have diabetes or lung diseases, often we'll treat people with what we call passive immunity, meaning monoclonal antibody therapy. That's where they engineered antibodies. So we make you immune by giving you a dose of this medicine. These originally, they weren't real impressive with their data, but what we know is if you give two different monoclonal antibodies, so antibodies that bind to two different parts of that spike protein, much more effective and really help keep people from dying and going in the hospital. The more encouraging data, and this is going to be hard to explain, so bear with me here. The AstraZeneca, a lot of questions about AstraZeneca. It's going to be an effective vaccine, but more importantly is sort of this existential question about the safety and the process of approving vaccines. And I think this AstraZeneca, a little bit of a blunder in how they reported their data. They released their results in a press release, and then that was scrutinized, and we came back and we said, hey, your figures on 79, 75% efficacy, you may have misquoted and cherry picked some of the data. And so what this means to me is that the process, the guardrails that are in place are working. The data is not being intentionally or accidentally falsified. The scrutiny is high, and the safety is ensured by this process. So we won't make any moves until the FDA's advisory group looks at the actual data. big difference in press release data. So what we saw is that our processes appear to be in place and are very encouraging to me that that we're looking at these vaccines really critically. We're not just pushing them through for the sake of pushing them through. However, if you do look at all of the aggregate data from the AstraZeneca vaccine, a whole new platform, or it's a different viral vector platform, 100% effective at preventing severe disease, hospitalization, and death. And then just today, data were released on the Pfizer vaccine where they gave it to a couple thousand kids age 12 to 15, 100% effective in preventing infection. So I never thought I'd see the day when we would be using 95 plus percent effective numbers for vaccines. A couple other quick things we've learned recently. School's likely safe. You know, a year ago when we talked about school opening, boy, we all had a lot of trepidation. We were scared. What's it going to look like when we send kids to school? Because we know in the winter, that's sort of the amplifier of respiratory illnesses. And what would happen when we reopen schools? Well, some big trials published by the CDC in Missouri and several other states have looked at, can you safely open school with some degree of mitigation, typically meaning mask when they're in the kids are in the classroom, and limiting proximity, maybe down to 3 feet. So it looks to me like big change from where we were a year ago, probably even 4 months ago, last time we talked, is that schools can be reopened safely if those mitigation strategies are able to be adhered to cautiously. These studies, the one in Missouri, they actually looked at kids that were exposed in the school. When you do this physical distancing and masking, tested those kids, and we weren't finding a high degree of transmission and asymptomatic infection in the school. So really encouraging data on how to safely reopen schools. A couple other things we know is that, we talked about these antigen tests and some of these less well-performing rapid antigen tests. We said, those aren't good. They're going to miss a lot of people. But something that we've learned in the last few months is that there are strategies to use those tests. It really has to do with the frequency that you administer those tests. So for instance, frequent testing on the same group of people, maybe every week, on regular intervals with rapid reporting of positive results can prevent ongoing community transmission. So that's a big lesson that we've learned in the last few months, is that while the test performance in any individual patient may not be great, it may have false negatives, it may miss people, but if you do it repeatedly in the community, the real world data that we've experienced now, it suggests that this can prevent ongoing community transmission. So that's a big lesson learned. And those tests are going to be available in schools, in higher education, in healthcare systems. We've been using them in nursing homes and things like that. So that's good news. Here are a couple questions that I want to field before we go to the online live questions. Does receipt of a vaccine change the results of a test? So the answer to that is no. The vaccines are spike protein antigen, so it puts spike protein into your body and you make an immune response, and it will not impact the results of a test. So if you are infected or not infected, the results of a nasopharyngeal PCR are what they are regardless of having received the vaccine. We know if you've received the vaccine, you're less likely to test positive, but the results should be interpreted the same in vaccinated people. I hope that makes sense. Another question is, another PSA is always get your 2 doses. You might have more vaccine-related side effects, meaning fever and fatigue. I know I did. My family did. The second vaccine, short-lived. You're going to have a little more side effects. Be prepared, but it's super important for the durability of the vaccine. We don't want people's immunity to wane after 3 or 4 months. So I really want to emphasize, get that second shot. And keep in mind, you can still test positive. You're still going to get exposed if we don't use the mask. Think about the distancing. All those mitigation strategies have to stay in place because there's still going to be sick people out there. They're still going to cough. You're still going to get viral RNA in your nose, in your mouth. You're going to test positive. The good news is you're much less likely to get sick. So we really need to keep our foot on the gas. I think it's really important that we all understand going forward, the vaccines are almost 100% effective in preventing death, 95% effective in preventing severe disease, probably 80% effective in preventing asymptomatic infection. That means 20% of the people still have the potential to transmit to those other vulnerable people who haven't been vaccinated. So these are all good. These are all good news, but we still have gaps. We're not quite there. These are the things we can do going forward. I don't think it's time to let our foot off the gas. We really need a large fraction of the population to be vaccinated before we feel comfortable that ongoing transmission in the community is going to stop. This number might be 25, 30% in a local community, assuming that maybe 25 to 30% of the population have already been infected. We know that the vaccine is not